Welcome back, everyone. We are officially on part 12 of our 20-part dental coding masterclass explainer. I'm absolutely thrilled to have you here today as we keep pushing through the complex, but honestly, super fascinating world of dental billing. Now, if you were with us for part 11, you'll remember we took a deep dive into documentation standards and charting, which is really the bedrock of everything we do, right? Well, today, we're shifting gears. We are going to focus on applying ICD-10-CM diagnostic codes in dentistry, breaking down the primary dental code chapters and, this is huge, mastering the critical Z-series guidelines for routine visits and surgical aftercare.
Here's a quick look at our agenda for today. We'll start with our welcome, cover some dental anatomy basics, dive into those essential Z-series codes, highlight the coding rules and audit traps you need to avoid, and then wrap it all up.
All right, let's jump right into Section 1.
Getting these diagnostic codes right is literally the difference between a clean, paid claim and a massive headache of a denial. To truly master dental coding, we have to remember that dentistry isn't just about treating teeth, it's about accurately diagnosing conditions. When we code for these claims, we rely on a few major ICD-10-CM categories. We use the K00 through K14 series for diseases of the oral cavity and salivary glands. So think of your everyday cavities, pulpitis, gingivitis, and periodontitis. Then we use the M26 series for dentofacial anomalies and malocclusion, like open bites or jaw relationship issues. And for non-fracture traumatic injuries to the oral structures, we look to the S00.5 series for superficial injuries. Your precision as a coder comes down to knowing exactly which of these categories accurately reflects the patient's condition.
Moving on to Section 2, Dental Anatomy Basics.
The truth is, you really can't code what you don't understand. A huge portion of the specific codes we use depends entirely on which part of the tooth is actually affected. When you understand the structure, from that hard outer enamel of the crown all the way down to the nerves in the pulp and the root embedded in the jawbone, you can see why a simple surface issue is drastically different from a deep infection. The codes we select have to tell that exact story. Is it just superficial, or has the decay reached the nerve?
Let's break these anatomical components down so you know exactly what you're reading in a provider's chart. The crown is simply the visible part of the tooth above the gum line. It's covered by enamel, which is incredibly tough. It's actually the hardest substance in the human body. Beneath that, you have the dentin, which is softer and makes up the bulk of the tooth. Dentin carries tiny nerve signals, which is exactly why your patients feel pain when decay hits this layer. Even deeper is the pulp, the innermost part containing the primary nerves and blood vessels. And finally, the root anchors the whole thing securely into the jawbone. Knowing whether you're dealing with superficial enamel or the deep pulp is absolutely vital for landing on the correct diagnostic category.
Okay, let's head into Section 3, Essential Z-Series Codes.
Now, unlike disease codes that describe a specific illness, Z codes are used when a patient isn't currently sick or when they're coming in for a very specific circumstance, like a screening or an aftercare visit. The most critical distinction you will make every single day is between routine encounters. A patient comes in for their 6-month prophy, their routine cleaning. If the dentist checks their mouth and finds absolutely nothing wrong, you code Z01.20. It literally means without abnormal findings. However, if during that exact same exam, the dentist finds a cavity or some gingivitis, the primary encounter code immediately shifts to Z01.21 with abnormal findings. It is a tiny change in the code, but a massive difference in how that chart is documented and billed.
Beyond those basic exams, we have a whole menu of Z codes that describe exactly why that patient is sitting in the chair. These are your go-to codes, and you've got to be precise here. For instance, use Z13.84 specifically for a dental disorder screening encounter. Z48.814 is a big one. That is strictly for surgical aftercare following surgery on the teeth or oral cavity. We use Z98.810 to indicate dental sealant status. What if a patient just pops in to have stitches removed after an extraction? That's Z48.02. And we can't forget our prosthetic and orthodontic patients. Z46.3 covers the fitting and adjustment of a dental prosthetic device, like a denture, while Z46.4 is for fitting and adjusting orthodontic devices, like braces. Nailing these encounter reasons tells the payer exactly what's happening, which paves the way for smooth reimbursement.
Let's move into Section 4, where we cover coding rules and audit traps.
We're moving from definitions to the actual rules of the road, the stuff auditors actively look for. Rule number 1 is super straightforward. If it is a clean bill of health during a checkup, Z1.20 is your standalone code. You don't need to add a single thing to justify the visit. The patient came in for preventative care, they got their evaluation, and they left with a healthy mouth. Z1.20 tells that whole story perfectly all by itself.
But here is a massive audit trap you have to watch out for. Never ever code Z01.21 by itself. This code essentially screams to the insurance company, hey, we found something wrong. Naturally, the very next question the payer asks is, okay, well, what did you find? You must pair Z01.21 with a code specifying the exact abnormal pathology that was discovered. If you bill Z01.21 alone, your claim is almost guaranteed to be denied or flagged. You have to follow it up with a specific diagnostic code, like a K-code for dental caries or pulpitis, so the complete clinical picture is there for the payer. And here is another really strict rule. Do not mix the restoration status code Z98.811 with the specific K-codes for fractured restorative materials. Think about it like this. Z98.811 is just a general status code saying this patient has a dental restoration. But if that patient is in the chair because their filling or crown actually broke, you have to use a much more specific code, like K08.530 for a fractured restorative material without loss of material, or K08.531 if the material was actually lost. Using both the general status code and the specific fracture code is redundant. Always code to the absolute highest level of specificity and avoid those contradictory combinations.
All right, let's wrap things up in Section 5, Summary, and our next explainer.
To bring it all together, always differentiate your clean routine exams from your abnormal findings. Use Z1.20 alone for a perfectly healthy checkup. If it's an abnormal checkup, use Z1.21, but you absolutely must add that additional code to explain the problem. And finally, keep your restorative material fracture codes isolated from general restoration status codes.
So we know how to handle the routine follow-ups and cleanings. But what happens when a patient comes in with severe dental trauma? Dental fractures can be incredibly tricky to code because of all the variables. Was it a restoration that broke, or the natural tooth itself? Was it due to some sort of trauma?
A deep fracture line running right through the enamel and into the dentin causes severe pain and requires really complex care. In Part 13, we're going to explore the exact differences between K-codes for fractured restorations and S-codes for traumatic tooth fractures. Plus, we'll dive into the required external cause of injury codes that you just cannot afford to forget. It is going to be a highly informative deep dive.
I really hope you found today's explainer valuable, and that these Z-code guidelines give you a ton of confidence the next time you sit down to work your claims. Are you ready to tackle the high-stakes world of dental trauma coding? We'll find out next time. Be sure to like, subscribe, share this with your fellow coders, and check the playlist so you don't miss Part 13. Until next time, keep learning, keep growing, and decode healthcare with Harshal.